You're someone with a vision for your practice, for your side hustle, and for your personal journey. But when it comes to establishing your path on how to get to where you want to be with your practice, things get a little messy. You're also someone who'd prefer to go in person instead of to groups and listening to everyone else's story. To me, it sounds like you could benefit from one on one consulting with our experienced practice of the practice consultants. From $5.95 a month and up, you can work with a consultant that will give you more direction and practical, tried and tested tips matched to you and your goals. For more information, visit practiceofthepractice.com/apply. Again, that's practiceofthepractice.com/apply. This is the Practice of the Practice podcast with Joe Sanok, session number 1381. I'm Joe Sanok, your host, and welcome to the Practice of the Practice podcast, where we help you build a thriving private practice you absolutely love. And actually, at the time of this recording, it's not yet the group practice conference, but when it goes live, we will just have wrapped up the group practice conference in Traverse City. So it's one of those things that we bring people together every year in TED Talk style, 20-minute talks on the main stage, and then a good third of the time is spent just breaking out into conversations and to get to know each other, to go beyond just information, but actually implementation and connection. So we're gearing up for that. When you hear this go live, we will have just wrapped it up. And actually on May 6th, that's going to be our team day where all of our team, we go do some fun things together. We might go wine tasting. We might go out to the sand dunes, all sorts of just really fun things that we could be doing that day. So really excited to have everyone here on the show. I hope you're thinking about your summertime and how you can either step back from your practice if you tend to have it be slower in the summer, or maybe you have some special projects that you want to work on. So if you are in community in the Practice Academy, you know that we've been talking about your summer slump and avoiding that and how to strategically use that time differently, either for yourself or use that on special projects, or maybe you've been working hard to make sure you don't have a summer slump. So as we kind of wrap up the spring, excited to dive into summertime. So I'm so excited today. We have with us Jacob Kendall, and Jacob is a social worker, gerontologist, and often says of himself that he's so macro, there should be a level above macro. He's had 2 open heart surgeries. He's been a full-time caregiver, and he has a med school and seminary degrees. The intersection between his personal and professional backgrounds have led him to create the 4D aging framework, a strengths-based model that challenges one-dimensional approaches to aging and health. He speaks and writes why we should be more pro-aging, and he consults with tons of different organizations that serve older adults as well. He sells memorial blankets with his wife, and he and his wife currently live in Mobile Bay with his son, daughter, and cat. Welcome to the show, Jacob.
Yeah, thanks, Joe. I appreciate the invite and opportunity to have a conversation.
Yeah, well, heart surgeries are big in my family, so let's start there. I mean, my great grandmother died young of, quote, heart issues. Then my grandpa had open heart surgery, and then my mom was the first child at Cleveland Clinic to have open heart surgery, and then my brother had open heart surgery, and both my daughters had open heart surgery. So it seems to be quite the line within my family. And so I know that when people deal with medical things, especially at a younger age, that affects and changes the way that they think about the world. How has 2 open heart surgeries affected the way you approach the world?
Yeah, I'll be curious to hear what kinds it is with your family. So aortic valve disease runs in my side of the family, my mom's side of the family. So several of us have had surgeries, most of us multiple ones. And my mom and I are actually the only 2 alive of our family who have had those. And yeah, I chose a procedure for the first one that was it was high risk, high reward, and unfortunately it didn't last as long as I wanted to. So now I have a mechanical aortic valve and I have to take blood thinners and higher chance of higher risk of stroke and whatnot. And it was that second one in particular that was a bit of a catalyst for making some changes. I got my PhD thinking that I was going to retire faculty, and I was faculty at the time, teaching global health. But when that came, it really gave me a different perspective. I'm like, I don't know that I want to work for the rest of my life with working toward tenure and having that.
Yeah.
Uh, and the entrepreneurial bug bit me. Um, so yeah, we've made a lot of changes. But then, I got married. My father died, so I moved. First, he got sick, completely debilitated. We had other plans right after marriage, but then we moved back home to Alabama to help my mom care for him. And then he died, and then we had both of our children a couple years apart. So a whole lot of things there within a few years that happened. But I am certain that my second surgery was a huge catalyst for that.
Yeah.
None of it happens in a vacuum, right?
Yeah. Well, and you're juggling it all even today. You say you have a sick 1-year-old daughter at home right now. So if we hear cries in the background, that's part of being a dad and a business owner and all of it. So I get it. So thanks for taking time with us today. So tell me kind of the overlap between social work and your PhD and just how you think so macro about the world and maybe what do we get wrong with aging?
Yeah, as far back as I can remember, I preferred an interdisciplinary approach. I much preferred to be jack of all trades rather than expert of one. I studied biology in undergrad, my true and original love, but whatever prompted me to go more the social sciences route, I did. My dad had a social work degree, and I thought that made some sense for me. I never wanted to be a practitioner, but social work does have this macro component. I knew that I wanted to get dual masters in public health and social work tend to couple well with one another. So I did the dual MPH, MSW. Again, I was all macro. I mean, public health is inherently macro. And then I went directly from that into the PhD program. I don't recommend that to even my worst enemies. That many years of grad school back to back to back. Technically, my PhD program was called Interdisciplinary Aging Studies. I just say gerontology because that's the definition of it anyway. And we looked at aging from perspective of pretty much every discipline, from
Mm,
molecular and cellular biology to neuroscience, all the way up to epidemiology. I was trained by a demographer, and so I really nerd out over, examining different population trends between different countries or whatnot. That's what I was teaching when I was teaching global health. I taught social work first, and then I taught global health. And you know, social work especially also has most social workers go into clinical work or very case management, very micro oriented.
mm,
Um, but I also, with my own complex medical needs, there's the individual side of it as well. And so I started seeing that, well, all these different things are connected, but we treat aging as just this medical issue, and we just expect it to sail off into the sunset and decline as we go along. But that's just not a sufficient or even accurate way of looking at it. And I
mhm.
developed my 4D model, not so much creating the design, but just giving a name to something that I've just observed, that I think that we need to approach aging from a very broadly disciplinary, multidimensional perspective. If we're only listening to our physicians, if we're only taking medicines for things to get better, if we're only focusing on patients and we're not also including families and caregivers, and what are the economic, cultural, political implications of aging, and not just that, but how is it tied to other issues like immigration, even AI, then we're not addressing it fully. So what I typically say is we're trying to solve four-dimensional problems with one-dimensional solutions, and that's just not going to
Mm.
work well. So to answer your question, there's a lot of things we get wrong about aging.
Yeah. Now, if we were to look at some of those one-dimensional approaches, like what is that kind of siloed thinking that people have around aging?
Yeah, well, certainly from an academic perspective, and some disciplines are quote unquote worse than others. And listen, it's good that we have experts. I'm very glad that the surgeons who did my surgery are absolute experts at valve surgery. I want that, you know. So we need experts, but it's really easy to get caught up in your particular way of thinking. So uh, Alzheimer's is a sexy topic right now. It's getting billions of dollars poured into research, and it should. Listen, dementia tears families apart. It literally kills caregivers. They have a higher morbidity and mortality, and it's a massive economic burden. And so that we definitely need a lot of that. But a lot of what we see with, I mean, we need to focus on it, but a lot of what we see with Alzheimer's is specifically focusing on the biomedical aspects of it. And again, that's important. But if we fail to account for the burden that it poses to caregivers, and communities and these other aspects of it, which I think that we do, then we're not going to address it very well. And so I think that Alzheimer's is largely seen as a medical issue that focuses on the person who has it, but we have to include families and caregivers within that. And we're getting better, but it's not to the point we need it yet. So that's one of many examples I could give of how that's a one-dimensional approach, but Alzheimer's is anything but one-dimensional.
Yeah. So you describe your 4D thinking as a new lens for aging. What are the four dimensions, and why do health leaders need that framework?
Yeah, I base it off the four dimensions of space time. I actually think there are more dimensions than that, but we won't go down there. It's too much
I'm with you.
quantum mechanics there.
Oh yeah.
So uh, the I've already talked about one of it, with zooming in and out. I think American individualism has gone way too far. I hear things like, a really good example, low hanging fruit kind of is, well, I don't want to support policies that help people with obesity. We have an obesity epidemic here in the U.S. Uh, because they just choose to eat too much. Well, no, obesity is also a systemic level issue. It doesn't all boil down to individual behavior. Individual behavior is important. We should focus on lifestyle factors, but they're not the only ones, you know? And so that proves to us that we have to zoom out to really see what's going on. An example here is when I first moved here, I have to immediately start establishing myself with providers. We moved here to Southern Alabama because I need a cardiologist, I need a dentist, I need a PCP. They're the most important ones, and I got to immediately get that for my own needs. And I noticed that things were backing up. I had to wait many months to schedule an appointment. The waiting rooms are full, and physicians are very hurried when they come to their appointments. And it's easy for me to blame them for taking on too many patients, but that's not what's going on. We live in the seventh fastest growing metro area in the country, and that's affecting healthcare access here, right? And you can't know that until you zoom out. You got to zoom out. So that's one dimension, is zooming in and out between different levels. Another one I've also hinted at is, what are different perspectives on disciplinary perspectives on a given issue. So we rely a lot on biomedical perspectives when it comes to aging. Our government hires more economists than they do other kinds of disciplines, but we have to know, we got to know, we need to be talking to geographers and anthropologists and demographers and epidemiologists. We got to know what family studies professionals. We got to look at it from these other perspectives as well. And then there's kind of the context. This is, I'm trying to visualize it. There's a context as well. So, aging, there's so much tied to your zip code. Zip code is very explanatory in terms of health, which shows us that the context in which you live matters greatly. And I think that the U.S., we're all about exclusion, what is the term? Exceptionalism. There's the term I'm looking for. But I think we need to learn from a lot of other societies about how to do things well. I did my research on aging in rural Malawi, and I think that the global South, so-called, has as much to teach us as we have to teach them. And then even within a given place, people who live in urban areas, if they're like poor people living in the same place, have aged differently than people who don't, or older adults who live by themselves. Isolation is a big thing. Have different experiences than people who live with their families. So context matters. And then finally, there's the time component of it. And I'll say two things here. One, we're really terrible at planning in advance. The reason that crises are crises is because we didn't plan for them ahead of time. Everyone, every single person, every single younger adult needs to expect to be a caregiver at some point, and then later than that, need a caregiver at some point. It's going to happen. There's absolutely no one who's untouched by any of that. And the other thing is, we assume that aging is just this chronological thing. Oh, your knees are getting bad. Oh, your back's getting bad. Oh, you're starting to forget things. That's just how it's going to be, and you got to deal with it. No, there's a lot that we can do. Aging is not simply the passage of time. It's not just chronological. Okay, I'll stop there. I just explained the four different dimensions. Feel free to ask any clarifying questions.
Yeah, no. I love that. I think that it raises for me even just something as simple as when you were talking about zip code. I remember Malcolm Gladwell in one of his books was talking about kids that were raised in really poor families in kind of a more affluent neighborhood that didn't have crime, didn't have that. that they were better off than those that had the same level of, say, wealth and, solid parents that were in a neighborhood that was more poor and had difficult, issues going around it, and that really your social group and the people around you help you kind of move into different things. And I love that you're saying, with obesity, it's not just obesity and that individual's decision. It's, if we look at food systems, if we look at how much, food has even changed since like the 60s and 70s, that just how much food is just packed with stuff that's so bad for us, that's outlawed in many other countries. And then, you just look at, the average person to just survive has to be two people working full time to just like make basic ends meet. So then it kind of steps into the economics of it. And when do you have time to exercise or recreate or do things that help you, just live a life worth living? And so I love that you're pulling it apart from that compartmentalized kind of singular way of thinking about things and saying these are complex issues. A year from today, what would your dream private practice look like? Would you spend less time chasing claims or only working with clients who value your skill set? What if you had a network to reach out to for questions or free continuing ed? What if you had more time for yourself? Alma empowers you to confidently accept insurance backed by an all-in-one EHR that simplifies scheduling, documentation, and day-to-day practice operations. With a network of engaged providers and free CE resources, Alma makes it easy for you to build the practice of your dreams on your terms. Alma believes that when therapists get the support they need, mental health care gets better for everyone. Learn more about Alma at helloalma.com/Joe. Your dream practice is closer than you think. Get started now at helloalma.com/Joe. That's helloalma.com/Joe. When we think about aging, I'm in my 40s. My parents are in their 70s. Right now, their health is good. My partner's parents are almost exactly the same age as my parents. So when you think about mentally preparing for being a caregiver, tell me more about that.
Yeah, I'll take a step back from that, and I think when people get married, or if they don't get married, when they start their careers, I mentioned earlier, younger adults, 20s and 30s, go ahead and start talking about, hey, let's get life insurance. Hey, let's have conversations not just with ourselves, but with our parents. Sit down and have those conversations like, hey, these things are going to happen. It is rare for someone to simply be healthy all across life and then die. Things are going to happen. And unfortunately, we live in a society and in a world where we're just terrified of death. And I firmly believe, I'm convicted, that the more we embrace our own mortality, actually the higher our quality of life. But we just don't live in a place where a lot of people consider it taboo to talk about their eventual demise, our dimensional demise, because we all do it. But I think that we should live in a society where those things are more openly discussed. And I think that it's getting better. It'll be interesting to see what today's 40 and 50, 60-year-olds, how they are in a few decades about thinking of their own mortality. So I do think that it might be getting better. I'm having some hope there. But right now, we're already amidst a caregiving crisis. So, you and I, we're dealing with this with our parents. So I think we just have to be open. But we have to be open with that about ourselves as well. So my wife and I try to have these honest conversations. I have major health needs, right? And I got to be near a hospital that has a certain level of stroke response center. And when we're talking about moving, which we are eventually, then that's something we have to take into account. We just need to be upfront about those conversations, and we should think about our own children as well. One day we're going to go, and we hope that we can set them up financially and otherwise to deal with those kinds of things. But I think bring it all back down to one point. I probably could have used far fewer words to say this. We all have to be more willing to just have the conversations about them. And again, if we do it, I fully believe that we'll have better quality of life. It doesn't have to be just this sad thing to talk about our own eventual mortality.
Well, I think it's interesting because when we think about, you mentioned American exceptionalism, or the myth of that, this idea of the individual, of all that we've lost by living in our own homes, living away from our friends and family. You look at so many communities that have multi-generational living, where being a part of that community is normal. That having an aging person next door to you, or having parents that either live with you, or and having those same parents maybe help when you have a sick child and you have to go to work. And instead it's like, you and I right now both have sick kids home, and we're working, and luckily my parents live in town and they could help if I was really in a pinch. But it's like that isolation, we've lost something in that isolation, in the United States. When you've done your research and looked at isolation and how that connects with a lot of kind of the multifacets of this problem, how does that play into it?
Yeah, for sure. I would say we have an epidemic of isolation as well, and we can't simply say, oh, let's try to encourage older adults to live with their adult children more. That's not going to work because migration is so common, and you have people move for a variety of reasons, and there's a term for it. I think they're probably still using it in academia, is intimacy at a distance. And so and I think the increase of age tech is really helping with this. Like, how basically what are the variety of ways that um, we can help people like you and me who my mom lives down the street, so I'm just saying people in your and my generations who don't live near our parents. But we're still caregivers for them. We're still handling a lot of things for them, and I think the increase in age tech, kind of just use an umbrella term there, is helping with that. But we have to think about those things because we're not just going to change the patterns. And I also I think like you said, it doesn't just have to be family members. I mean, think about an aging friendly community or city, right? And there are kind of pockets here and there of good examples. Um, but think about the things that need to be in there for an aging friendly city. Think of the features: good sidewalks, safe sidewalks, well lit at night, safety, green spaces, easy access, whether it means walking or taking public transportation to pharmacies and banks and churches and the necessary things that people need in their lives, and having opportunities for people to engage with one another. These variety of things. Now, tell me that you would not want to live in a place like that yourself.
Right.
tell
Yeah.
me tell me that you would not want to raise your children in a place like that. So it's really interesting. And I would say the same thing for disability. When we actively and intentionally design for age and for disability, we're designing for everyone. And that's how I think that we should think of it, is that this is not just preparing for our own older age. This is giving us all a better life. And so that's kind of a couple different things that come to mind when you ask me that question. I don't even remember what your question was, but I think I may have answered it.
No, you totally did. Well, I love that you talk about age tech, because I want to know, like, what role do you think technology realistically plays in extending not just lifespan, but maybe health span?
Yeah, some examples I'm seeing are either they're apps on your phone. There's one company I know that they use smart TVs for it, but it makes it easier for older adults to communicate via video, especially with their loved ones. It makes it easier for their loved ones to know what's going on with them. Like, hey, did you go see the doctor? Did your meds change? Did you fall yesterday? Those kinds of things, and simply talk to them, and that helps as well, even if you're at a distance. And so that's pretty simple stuff when we're talking about tech. I think that AI, and AI is a separate conversation. I don't love the direction that it's going, but it's here and it's not going to go away. So how can we use it for good? And there's some ways that AI is being used. Things like challenging. I know another company that they use an AI powered app to help patients challenge denied insurance claims. And it happens a lot easier because that's a really beefy process, and a lot of people don't want to go through it. Making things like that easier. And if you want to go super tech, caregiving robots. I think they may have started in Japan. They'll probably eventually find their way over here. They would have to start in a place like Japan where they have no immigrants to help, because immigrants are a huge source of home care here in the U.S. Japan essentially has none of those and an older population than we do. So it would make sense if something like that were invented there. But this is literally an AI powered robot. And it's going to be interesting to see. We're already seeing examples of people that's basically building friendships with AI. Again, I don't want to. I'm trying to avoid the bad aspects of it. I'm just telling you that tech is there, and it's going to be increasingly used. So we need to learn how to adapt to it. But those are a few of many ways we can talk about age tech, and there are a lot of uses for it in medicine as well. But I won't go any farther.
I would argue that Luke had a relationship with C-3PO and R2-D2, and that wasn't a bad thing.
Well, those were droids, which are almost living things.
Right. So our AI powered droids are coming to help mom and dad. So
you can always reference Star Wars and get me to smile. I appreciate that.
No, I love that. I'm wondering if we were to think about big healthcare shifts, like if you could wave a magic wand, or all the healthcare executives were listening now, or policymakers, and they said, okay, Jacob, tell us what some simple big shifts. And I know that 4D is never simple. That's kind of the whole thing, is that you can't just distill it down. But like, what are some policy changes that you think would move us in the right direction?
Well, I'll go ahead and preface this by saying that just about any suggestion I could come up with, we're probably going in the opposite direction. Here's one example. There was recently a list of degrees that came out that are no longer considered professional degrees. So this is going in the opposite direction. Social work is one of those, which I think is absolutely absurd. Social workers and similar kinds of professionals need to be more centralized on interdisciplinary medical teams, because they do the work that no one else wants to do. They do the work that other people don't know how to do, but they're not compensated for that. It is difficult to bring everything together, from the pharmacist, from the nurse, from the physician, from all the dietitian, and discharge people and make sure that they're going to be connected to the resources that they need once they leave the hospital. That's really, really important. And the amount that social workers are paid, if any social workers are listening to me right now, I know for certain that they're going to agree with me that they're not paid to reflect the difficulty of that work. I think that we need to drastically restructure how we value certain kinds of services. We can see this with nurses, who as a profession have successfully advocated for themselves. You get higher pay, a little bit more power in the medical setting. So we can see examples of how this could work. As far as I know, we don't have that kind of thing going on in social work. I don't really know why. So that's one thing that I would say. I think that we need to get away from treating human bodies as commodities. And listen, when I talk about this, inevitably the question comes up of, well, how are you going to take this to the very top and make these changes with insurance companies or the medical industrial complex? I'm not going to try to. We'd have to convince billionaires to stop loving money. That's not going to work. But you asked if I can wave a magic wand, not a realistic one, a magic one. I think you used that term. So ideally, we make it to where the patient and the family are in the center, and all the pieces are around them. That's not how it is now. I do think that medical providers are getting better, that they hate insurance companies as much as we patients do. But there's still a long way to go. So our system is it is an absolute fact that it functions. There's more profit for the medical industrial complex when Americans are sick. Bottom line, they do not want us to be better. And this is not some conspiracy thing. It actually works that way because it's a for-profit system. That's how for-profit works. Apple makes more money when more people buy their phones and computers. The same is true with healthcare. And I'm not going to sit here and say that a totally government subsidized system or some kind of socialized medicine would work here. I think the U.S. is probably too large for that. The only thing I'm pointing out here is that the current system sucks, and this is one of the reasons why. So I'm really getting on a soapbox here. I could go off the rails pretty easily.
This is a soapbox worth being on. The last question I always ask is, if every private practitioner in the world were listening right now, what would you want them to know?
Yeah, one of the earlier businesses that I had, and I still do have clients, but every now and then, but I limit it because I'm focusing on other things. It's called the Versatile Social Worker. The versatileSocialWorker.com is career coaching for social workers, because what we're seeing right now is a lot of social workers and other mental health providers are pissed off with the status quo. I mean, there's this debate right now. I see posts on it all the time. If you stop taking insurance, are you being unethical? Because if you stop taking insurance, then you can do self-pay and you can charge whatever you want. But that means that you're not serving people who are lower income and can't afford that. Listen, I say, yeah, you and yours come first. There's a reason they tell you, put your own oxygen mask on first before you help other people do it on airplanes, right? And what we're seeing right now is a lot of burnt out social workers, a lot of burnt out mental health providers, and they're not any good to the people that they serve if they eventually are getting burnt out. And so they're wanting to leave and go to other places. And I help them do that. I help them find more macro jobs. So I would say, if you can relate to that, then be creative. I can't tell you the number of times I've heard, well, all I know how to do is case manager. All I know how to do is clinical work. And I'm like, there's nothing all that you can do. There's nothing limiting about what the education that you have. Is just about being creative. So I'm all about, hey, try to be more macro, try to see that you have these skills that apply in other places. And I'm not telling people not to be therapists, because we need therapists in this world. What I am saying is there's a lot bigger world out there, and don't limit yourself. I've seen it too many times as social workers. They limit themselves, and it's a part of the systemic issue. When you hear things like, oh, well, you go into this profession for the outcome and not the income, and you hear bullshit like that, pardon the language, I forgot to ask if that's okay. When you hear crap like that, then you internalize the message that your skills aren't worth that much. And that is stupid and dangerous. And so I'm getting another soapbox here. I would say, say the way that you are trained by like when you're trained in school, they're not going to tell you how to adequately value your skills. It is up to you to do that for yourself. But there's so much that you have to offer, whether it's therapy or otherwise, and don't sell yourself short. Okay, I'll stop there.
Love it, Jacob. Yes, more of that. We need more of that in the world. If people want to connect with you, if they want to follow your work, where should we send them?
Sure. If you're looking to pivot, then theversatileSocialWorker.com, career coaching, whatnot. If you're interested in buying a customized memorial blanket, thelastingremembrance.com. If you're interested in me speaking about the things that I speak about here to your organization or on stage, then it's 4D as in dimensional 4Daging.com. Even if you just want to follow what I do, it's Jacob Evans Kendall at LinkedIn, and I'll send you all those links.
Love it. So awesome. Yeah, check out those show notes if you want any of those links. Dr. Jacob Kendall, welcome, and thanks for being here today. This has been amazing.
I enjoyed the conversation. Thank you.
You know, I love that final message from Jacob, that we don't have to just stay in the case management or in the therapy if we don't want to. We do need those people, but you know, it was back in 2012 that I started dreaming up Practice of the Practice, and just thinking about how I had a full-time job going at the time. I had a part-time counseling practice, and I knew nothing about the business world. And I thought, you know, there's nobody podcasting about this. And so we were the first podcast all about kind of the business and running of a private practice. Now, of course, over the last decade plus, we've wiggled, you know, in and out of all sorts of therapeutic issues and business issues and all sorts of things. But it all started with my curiosity. It started with me saying, you know, what does it take to build a strong private practice? And, you know, now we've interviewed over 1,300 people to just dig into what does it mean to be a therapist. And, you know, therapists aren't just in private practice, they're all over the place. And so we continue to explore this topic 3 times a week. We're so glad that you join us. We couldn't do this without Alma, our sponsor today. Alma is going to help you accept insurance. It's also backed by their all-in-one EHR. They have free continuing ed as part of it. They really help you build that practice that you'll absolutely love. We want to help you out by going over to helloalma.com/Joe. Again, that's helloalma, ALMA.com/Joe. You can have a conversation with them to see if they might be a fit for you. Thank you so much for letting me into your ears and into your brain. Have a great day. I'll talk to you soon. Special thanks to the band Silence is Sexy for that intro music, and this podcast is designed to provide accurate and authoritative information in regard to the subject matter covered. It is given with the understanding that neither the host, the producers, the publishers, or guests are rendering legal, accounting, clinical, or other professional information. If you want a professional, you should find one.